age of 18. Another thing that's important is just noting that mental illness has long-term ramifications on the child, their family, in many different ways, on their society, on their education, and on the economy. Okay, so I'm just going to take a zoom out quickly because we've been throwing the word health systems around and sometimes it's not quite clear what people are talking about. But the World Health Organization developed a framework called the WHO 6 building blocks of health systems. The 6 building blocks of health systems, and these are leadership and governance, financing, health information systems, the health workforce, health services, and access to essential medicines and technology. And it's important that we keep all of these in mind because as clinicians or health professionals, we often tend to zoom in on service delivery and health services, and maybe the health workforce. But if we don't keep in mind all of these building blocks, that's where we start to drop the ball and we can't bring things together in a meaningful way because we don't have the data, or there's no one who's overseeing things, or there's no budget. So these are all things that we need to keep in mind when we think about child and adolescent mental health services and systems. The other thing to keep in mind is that these are sort of the hardware components. So these, according to Gilson, these are the structural components of a health system. So it's the things that we can see. But there's also software elements, and these are the norms, the traditions, the values, the procedures. And we often see that these are the things that are sometimes a bit more difficult to shake, that type of resistance and the sort of entrenched beliefs that people have who are part of the health system. Okay, so the WHO also made this optimal mix of mental health services, and this is just to show you how they propose health services should be set up for mental health. So the bottom of the pyramid or the base of the pyramid should be informal services. So that's community-based services and self-care. So we need to really work towards strengthening those things. So strengthening community projects, strengthening the people who are able to engage with young people on a day-to-day basis, be it teachers, youth leaders, those are all things that should be embedded in the community and should be able to manage the majority of children before they actually end up having to access formal services. And even within formal services, the majority of services should be offered at the primary care level. So there's really a push to strengthen grassroots level service provision. Okay, so now we'll talk about what things currently look like. And some of this data is a bit old. It was published in between 2020 and 2022, but the studies will have used data that they got between 2016 and 2018. So in terms of the health workforce, it was found that there are insufficient specialists. There are few district mental health teams. So I think there were only 2 provinces that actually set up district mental health teams. There's limited training available. There's some anecdotal evidence of training that's taking place, but nothing is being documented and reported in a way that we can actually see that training is being provided. So primary care level staff are not on paper getting any training for child and adolescent mental health. And then it was found that there's an excessive workload, and with that workload, it's also to do with the fact that with child and adolescent mental health, it's about the quality more than the quantity. So there's a big push for the amount of patients seen rather than the quality with which those patients are seen. And then there's also limited allied staff. So this is across the board. OT, speech therapists. Child and adolescent mental health is a multidisciplinary field, and it really needs everyone to work together. So if you've got situations where other professions are lacking or there aren't any posts or no staff, then it's going to be a problem. And we found that was predominantly at the secondary level of care and at the primary level of care. Then under service delivery, no age-appropriate services. So for example, children are being admitted in pediatric wards where they're exposed to children who are actually physically sick with various infectious illnesses, for example. And then adolescents are being admitted in adult wards where they're exposed to patients that are psychotic, adult patients that are psychotic or acutely unwell. And that has put them in very dangerous situations that times, with a recent case in the Western Cape of a child being sexually assaulted, or an adolescent being sexually assaulted. So there are limited psychosocial services, inappropriate referral pathways. There's no dedicated funds, no costing and budgets, no disaggregated information with regards to the funding. So you'll see that the funding for district is this much, but you won't be able to tease out how much is being spent on child and adolescent mental health. And then it's not explicitly included in the national health insurance as it stands. And then in terms of leadership and governance, there is a child and adolescent mental health policy from 2003. So it hasn't been reviewed, it hasn't been revised, and it hasn't been implemented. No province had an implementation plan since 2003 until now to implement that policy. So again, we see this recurring theme of South Africa having very good policies, but very little implementation. There's no provincial oversight in any of the provinces. Recently in Western Cape that has changed, but someone else will elaborate on that. And then there's limited intersectoral collaboration. With regard to information systems, which drives the amount of resources that can be allocated to child and adolescent mental health, there's no age disaggregated data. So currently, the data is divided up until 15 years and over 15 years, which means that we don't actually have a good sense of what the need is for child and adolescent mental health. And then there's inadequate and inaccessible data. So even though, for example, in the Western Cape, there are health systems that are in place, it's very difficult to access some of that data and to analyze and use it in a meaningful way. And then there's also very limited research being done in this field. And then in terms of essential medicines and technologies, the good news is that technically we do have access to each drug class at each level of care. The bad news is that the availability of those drugs doesn't always translate. So we suffer from stockouts. And then there's also and then there's a lack of equipment needed for therapy. So with children, it's not about drugs, to be honest. Psychosocial interventions will probably be the bulk of what you're going to do. But there's no access to, for example, toys. There's no access to a space that is conducive for the type of therapy that needs to be given to children. And there's no technology to support data collection. Okay, so I'm going to end off there. I've told you a lot about what the problems are. The next three speakers are going to tell you about what the people on the ground are doing to try and remedy those problems. So I'm going to hand over now to Laurie. Thank you.
Very much, Simpiwe. And I just wondered if you could comment on the treatment gap, the extent of the treatment gap for adolescents and children.
Okay, so the mental health treatment gap for adolescents and children is 90%, which means that only 1 in 10 of the children that need care actually receive it or are actually able to access treatment, which again means that there's 9 children who are sitting at home, or 9 ill children who are sitting at home without any form of intervention or care.
Thanks very much. So it's quite a serious problem statement. And now we're going to move on to solutions. It gives me great pleasure to introduce Dr. Renee Nassen. She's, I've got to remember, a fellow of the College of Psychiatry. She's based at the University of Stellenbosch. And she is the provincial lead for child and adolescent mental health in the Western Cape. And may there be many, many more around the country.
I hope so. Thank you for the opportunity to speak. And I'm happy to say that maybe, just maybe, we've moved along. We laughed when you said it's old data, but since then things have moved along. And I want to start, I'm going to share with you the beginnings of, and hopefully an implementation, but start with something shared with me by a colleague last week. We were doing a training, in fact, our first CAMS training under the banner of the Strengthening Project. And she mentioned either the head or one of the directors of Pfizer, who said that considering the speed of developing vaccinations, it felt like they were riding a plane before the plane was built. And I can say it certainly feels like that at the moment. So I hope that we don't crash. So also starting with a problem statement, unfortunately, and I'm sure most of you are aware that child and adolescent psychiatry is classified as a subspecialty, which is a problem because the resources actually are commensurate with that status. But if you consider the pool of potential clients, that we've got 21 million children with 21 child and adolescent psychiatrists in public posts in the country, 6 of us in the Western Cape, with 1 vacant post. So there are 7 posts for 400,000 children. That's the extent of the specialists, at least in terms of child and adolescent psychiatry. And in terms of formalized CAM services, it is entirely located at this tertiary platform. And we are certainly reaching saturation because for years and years, we've had referrals coming from the primary system rather than any kind of interventions that could happen there. So we know what the policy, the condition of the policy is. It's rather old, but it did say that 80% of patients should be seen at primary level. However, there is a paucity of appropriate knowledge and skills. District health teams are generalists. They are overstretched, they are overworked, and many of them are resistant to actually taking up CAM's work. So even if we fix the teams, give them more skills, there are still children at primary level who require the services of specialists. And considering our country and the circumstances of many children, many of them actually cannot afford to reach a service at a tertiary site. And then, of course, we've set the mantra of task shifting, but it has its benefits and its dangers. It requires a lot of close supervision. It's not an easy thing to do when it comes to child and adolescent psychiatry. Simpiwe has shared with you some of the challenges that we are facing. And so just to share a little bit more about what we are experiencing in the Western Cape and specifically the Metro, there is certainly a greater focus on hospitalized kids and acute care. We've had an absolute deluge of adolescents, particularly requiring hospitalization for psychosis, but also because of suicidal behavior. And we all know by now about the poorly developed services for common mental disorders at primary level. And so the service pressure has also unleashed certain and particular risks that has required better service coordination. And these risks are the highly aggressive patient, but particularly those presenting with suicidal behavior and autism spectrum disorders. I was watching all the data and the stats that was shared with us this morning, and I went and looked at our suicide stats that get shared with me, and I thought I'll share that with you, that up to August this year, 52 children had died by suicide in the Western Cape. 14 of them were between the age of 10 and 14, and the rest 10 and 15, and the rest 15 to 19. And that's probably 2/3 maybe of the total, because there certainly would be more suicides towards the end of this year. And then from a systems point of view, we have grappled, struggled, but I think so slowly achieving a closer working relationship with the other sectors, Department of Social Development and Education particularly. There's something about COVID that has really been amazing, because we've spoken to different people, we've spoken to each other, we've broken down the walls and the silos, and long may it last. It's just the pace is very hard for us to keep up. It's like people are continuing with this kind of COVID pace. And so everything has to happen yesterday. And then, unfortunately, we also have the issue of children requiring child protection services, many of whom actually land up in a mental health facility because in the Western Cape, the Department of Social Development has exceeded their capacity to accommodate all the children who actually need to be removed from home, which is a sad indictment of our society, isn't it? So what are our strengths? Before I mention the research, one of it is that we've got an adequate macro level governance system, I would say, and we've got decent infrastructure, but it's not perfect and certainly not fit for purpose for children presenting with mental health problems. At a micro level, there's a lot of work to be done when it comes to governance, but we are paying attention to it. And then what we've got is that people are dedicating themselves to doing research in CAM strengthening. One of them is a colleague who is here at the moment, Dr. Stella Mokatimi, who has done a PhD, and you've heard that Simpiwe Simelane is also doing one. And her study has had a couple of key recommendations related to policy review, service development, training, and research. So let me share with you the CAM Strengthening Project. I was appointed as the coordinator or lead for child mental health services in the Western Cape about a year or so ago. And I'm sure, like everywhere else in the country, very much a part-time service, but the expectation of a miracle. So my day job is to lead one of the 3 CAM services. And in addition, and part-time, I do the coordination and hopefully the creation of something that will get us out of the starting blocks and towards implementation. We went through a process, a theory of change process in August last year, and with a promise of a lot of money. And unfortunately, as a colleague of mine will say, lots of wheels spinning went on, and we were very excited. And we presented a proposal that was going to be very costly, but which we, and I'm speaking about the 3 CAMS heads and our professor of child psychiatry, believed that that would adequately, in a way, solve or go somewhere towards solving the problem. Unfortunately, at the beginning of this year, it was revealed that we will get 6 million of 30 million to strengthen mental health services, and only for this financial year. So I had to become a miracle worker and try to drive a plane that hadn't been built. And so what do you do with 6 million that you're only going to have for a year with no promises of another injection of money? So one of the things we were obliged to do, and unfortunately it gobbled up 2/3 of the cost, is that we needed to increase adolescent beds because of the pressure and because of the risk of young people in district hospitals alongside adults. And you heard about the incident that occurred. But the second and more exciting one was that I was able to appoint a very dynamic team, all very much part-time, but wow, how amazing have they been, including our Simpiwe. And what we then had to do was to take a system strengthening and strategic approach to focus on aspects related to service redesign around a couple of key core activities. And we decided that we would do this alongside the mental health coordinator for Khayelitsha Eastern Substructure, who happens to be Dr. Mokatimi. So the proposal that I submitted was for people to focus on a couple of key areas. I didn't get funding for the first one, and so I hustle at the moment with volunteers, but did get funding for the others. So one of them, which is Simpiwe, is looking at core competencies towards a redesign of care packages. And then there is a child and adolescent psychiatrist who is leading CAMS training for the primary platform. But included in that is that we are having quite intense discussions to launch a postgraduate diploma in CAMS for generalists. And then a psychologist to look at a psychological framework fit for a primary platform. We can ill afford psychologists seeing people for an hour in the primary platform when there are so few of them. And then I felt that it was very, very important that we have an early years prevention and early intervention project. And of course, as part of this, there was going to be lots of engagements with experts and so forth. So I had to present a roadmap for how we're going to go about this. The team was eventually appointed on the 1st of August. And it was decided that we would focus on a learning or pilot site initially, and then focus on the key areas. And there have been multiple engagements, quite head-spinning, with various managers, with the different sectors, with researchers. By the way, you all know this, that the lead up time between research and implementation is what, 17, 18 years. And what we wanted to do was to say, we know that the research is here, how can we implement it? So we've got some of the researchers on board with us. And then, of course, needing to engage with the NPO sector, and there are some excellent NPOs in the Western Cape working with children. By February next year, and the managers are very impatient, by the way, I just need to let you into a secret. I've been a child psychiatrist for 20 years, banging my head and kind of cursing because we were essentially ignored. It was not a priority for anyone. And then COVID came and we know what happened then. And now I have managers who can't wait. And I said, no, you will wait. Because we are going through a process now of making sense of the first phase of the activities that has happened so far. And hopefully by February, there will be a report with some kind of an implementation plan. Now, I don't claim to say that we will have it all down as a blueprint. This is really going to be quite an organic process, but implement we will. We have to do it. We cannot wait, and certainly I cannot wait a year longer. And then, of course, we will have to, as part of phase 2, focus on the high-risk populations, particularly a framework and some kind of standard operating procedure for managing suicidal kids across the sectors, from the schools into the primary care facility and so forth. And in addition, kids with autism, and that's a talk on its own and a big problem on its own. We are going to have to grapple with the governance for CAMS, and hopefully in 2023, probably later 2023, a rural pilot. So how did we start? So we started in a suburb called Macassar. It's got an interesting history. And it's got one community health clinic. It's got an NPO called Community Keepers that does excellent work in schools. And it's a very nice and defined area. And so we've had to engage with all of the managers to get going. And we've had some meetings and visits to the community health clinic, including the birthing site or the MOU. And in addition, there have been some other engagements in the other substructures. For example, in one of our other substructures on the western side, the managers decided to appoint a psychologist just for CAMS. Now, it's very interesting. We are not a very big geographic area. I think there are 8 sub-districts, and they are all little islands of their own, it seems. And they all do things the way they see fit. So Kylie Cha-Easton has a coordinator for mental health, so it's easier for us to work with them. And then, of course, there are lots and lots of partnerships that we're trying to build. But in addition, we've come some way to forming a closer alliance with pediatrics and child health. I was invited to sit on the PCGC, or the Provincial Clinical Governance Committee, for which I'm very grateful and envious, I have to say, when I see my pediatric colleagues in action. And from a systems level strategy, the questions are, what are we going to do in addition to the 4 key areas, and how are we going to do it? So the first thing is we've got to define the CAMS platform, and it doesn't mean that because the formal services are on the tertiary sites that CAMS doesn't happen on the primary sites. It does. It happens everywhere. It's just very, very fragmented and poorly coordinated and led. And then, of course, we have to define the competencies for primary clinicians within a solid governance framework, and hopefully in a year or two's time, a CAMS service delivery framework. We really have to take this slowly and systematically because there is an enormous amount to do. And then, of course, incorporate the research, and I'm feeling quite enthusiastic so far that we will be able to do it. And we are deliberately and overtly cross-disciplinary. And we have to do that for our very survival. We are tiny subspeciality. And so there's got to be lots of consultations. But one of the positives has been the engagement with public health people in our metro to do with data tracking and information systems, and we're really building good data. So there's been some improvement on that as well, including the creation of a dashboard to monitor risk so that we can actually watch what is happening across the district hospitals in terms of suicide and so forth. What about the tertiary areas, tertiary sites? There are 3 of us, as I said, 1 affiliated to UCT, 2 affiliated to Stellenbosch University. We relate to each other very well when it comes to teaching and training. In fact, we've got our subspecialist training as a combined inter-university initiative, but we are less efficient, I would say, when it comes to a collective service delivery approach. I do believe that, considering that we are mandated to provide outreach and support, that we do not have the capacity to do this. And what I will be submitting, and I know that I'm going to be told that there's no money, is that we are going to have a more hybrid approach in terms of how we are going to provide services, and with the development of outreach teams that straddle the tertiary and the primary sites. And then, of course, there have been some other activities. I've mentioned pediatrics and child health, and I hope that we will be able to host rotations as we go along, and we are working quite hard to align in intellectual disability services for children with CAMS and so forth. We need to look at models of care, and probably we'll be looking at one of the models, like the collaborative care model, if that would be one of the, or an adaptation of it that we could utilize as part of our framework. So, in conclusion, I've got more questions than answers, as you might have noticed. What would be the most economical and viable model to roll out to strengthen CAMS nationally? And again, I don't claim that what we are doing in the Western Cape can easily be rolled out, but maybe there would be some learnings from that we could share. And the second question, is it realistic to believe that all it takes is to maximize existing resources via a system strengthening and coordination? And I really don't believe that that's true. I'm just missing a slide. Can I just go back quickly, because it is something I want to share with you. Just give me a moment. Hope it hasn't disappeared. There it is. I don't think I shared this one with you because these were some of the questions. So one of the questions was about strengthening within our existing systems via training and improved network and networking and so forth. And one of the other issues that we need to raise here is it's not easy to align existing service delivery frameworks. We are very committed to integrated care. Everybody speaks about it in the Western Cape. We've actually got integrated stationery, but people are overworked. People don't have the time, they don't have the skills, and they're burnt out. So how on earth are we supposed to do this when you look at the stationery and there's a small space that really is, it was designed for people with medical problems. And I really don't think that it's very realistic. But in addition, if you look at our kind of policy frameworks or guidelines, they don't quite align with trying to strengthen CAMS at primary care, because it very much is about referring rather than let's build on the primary platform. And so what I think we're probably going to move towards is a more hybrid model of integrated care alongside specialist teams. And that's what I'm talking about when I spoke about the outreach teams. So apologies for missing that slide. So the last 2 points or 3 points, we're not going to succeed without a massive culture and attitude shift. And I do believe that we're moving in that direction because everybody recognizes the urgency for change, but we still need to do a lot of buy-in from our generalist colleagues to take up some of the work. And I do believe we need additional resources, whether we like it or not. And we need to invest, and it's not just a financial investment, it's about investing by paying attention to this. But it's also been a great opportunity for clinician leadership. I've been in meetings that I've never been to before. I've had conversations as a clinician manager with people who have been so remote that we didn't know what each other looked like. So COVID has done that. And hopefully it's going to result in a quicker uptake and the change that we so sorely need and want. Thank you very much.
Thank you very much, Renee. As you can see, it's a huge challenge to transform an existing system, and just really exciting to see that the work that the Western Cape team has taken on. So now it gives me great pleasure to introduce Gillian Douglas. She's based at Queen Nandi Hospital in KZN, and she's going to give us a sense of what's possible in a more rural setting where perhaps there's a little bit more freedom to move.
Good afternoon, everybody. I hope you're all still awake. Maybe you should just give a bit of a shake. You've done so well, guys. You've done so well. Okay, let's move. So I'm going to be talking to you about the work that we've been doing. It's been very, some of it's unplanned, some of it's just happened, but let me tell you, and let me share with you what's happened. So for those of you who don't know, KZN is up in the corner there, the green. Okay, specifically, I'm working in Gwelazan Hospital and Queen Nandi, which are represented by the 2 green dots. You'll see that we service 17 district hospitals, 3 districts, 3 CHC. So that's our catchment area. I had all sorts of statistics about numbers and stuff, but I'm not going to do that right now. But you can see the distances are far, and it's a big area with many, many children in it. So it was quite good. When I was doing this preparation, I was actually thinking about what are the people resources that we've got. We screen sharing, so we've lost some of our psychologists. So we actually have 10 psychologists between Queen Nandi and Nguelazan. They aren't lost, they're still there. They're just behind the screen. We have 3 psychologists that are between our 19 district facilities. We've got 1 community service psychologist. Most community service psychologists in KZN head towards Durban and Maritzburg. We have 3 registered counsellors at our CHCs, which is a new thing, which is we are grateful for. We have 2 general psychiatrists based in Nguelazan, 1 rotating psychiatry registrar. We have psychiatry medical officers who have some with varying experience. We have the medical officers. I'll talk more about them in the district hospitals. We have mental health nurses in district hospitals. And one of the big game changers for us has been the specialist trained child and adolescent mental health nurses. We also have 10 pediatricians, hey, at Nandi. So, and pediatric medical officers. We've got OTs at Nguelazan and Queen Nandi and at the district hospitals. Some of those are community service ones, some of them are permanent staff. We've got social workers at all the hospitals. There's a school health system. We've got primary healthcare nurses and quite a developed clinic system. We've got community healthcare workers, and we've got 2 Renes, as it were, in Durban, who are our referrals in terms of specialist child and adolescent services. So part of what I'm going to be presenting is a package of mental health services. So we're looking at community and clinic-based services, district hospital services, and tertiary services. So our approach has had to be a little bit more integrative in that we have 4 focus areas: acute services, community services, child and adolescent services, and substance abuse services. And child and adolescent work has overlap in all of those. Actually, we have some child, particularly adolescents and some children, who fall into our acute services, many in our community services, and in our substance abuse services. So just to give you a little bit of background about these child psychiatric nurses, between 2018 and 2020, KZN Department of Health sent 70 nurses over this period of 3 years to be trained by University of Free State in child psychiatric nursing. We developed a specialist job description, so they are all recognized specialist, psychiatric specialist nurses. So there's a bit of an increase in terms of pay as an incentive. It's a tertiary-based training, so it's at a tertiary center in Bloemfontein. It's a year-long full-time program. What has come out of it is that there's a real need for ongoing supervision and support. 1 year's training in child psychiatric nursing does not equip you fully. You really need further supervision and support. And an important part of developing their role has been an engagement with particularly the nursing management in terms of understanding their placement, to provide a space for them and a role for them. You can imagine that they came in at 2020 when the full complement were trained, and then COVID hit. And that COVID just took over everything, as I'm sure it did for many of you. So we've only really got going with our program again this year. So in our region, we have 20 nurses. 3 are based at tertiary level, between 1 at Queen Nandi and 2 at Nguelazan, the 2 major hospitals. And then 12 are based at district hospitals, at CHCs and in school health. 1 has become a mental health coordinator, which is not a bad thing, actually. And unfortunately, and very sadly, we lost 1 of our nurses to COVID. And 3 of them have moved into different but related health fields. It's interesting, none of them are working exclusively in CAMS, because most of them are also the designated mental health nurse in their facility. So no full-time CAMS nurses, so just a little indication of where they went. So that's a map of KZN, and the different dots, the colors of the dots represent the different years in which they were trained. But you can see there's a sprinkling of them all over KZN, which for me is a very exciting thing. I don't think it's been utilized enough. But so you can see our corner up in the top there, mostly in the sort of greenish area. We live in a very beautiful part of KZN. So what are we doing? We're trying to grow each level. So if we look at community and clinic, we have found that, as Renee was saying, that as a result of COVID, there's been a really heightened awareness of mental health issues. And to be honest, it's really benefited us. The fact that I have 10 psychologists working between Ngwelezan and Kwinandi is a miracle. 10. I mean, where else do you have 10 psychologists? And it's a result of COVID that people recognize that we need mental health services. So some of the stuff we've done, we've just starting some basic counseling skills training with the nurses. So that's generic. So that really covers both children and adults. We're involved in research into a screening tool in collaboration with the Center for Rural Health for use by community health workers for screening for early mental health programs. That's at a very early stage. We've also worked with particularly one of the district mental health coordinators at the inclusion and strengthening of integration of mental health into the PHC nursing in-service training and including a CAMS component to that. We've taken very baby steps in training of the MINT program. I don't know if any of you are aware of it. It's basically a grassroots counseling program. We've also learned some important lessons in terms of what is called crash and burn. So just in terms of training community health workers, the degree of emotional weight, I think, that comes with work in CAMS must not be underestimated. It's difficult work and it's often very evocative and staff really struggle. And so we've had 2 or 3 of our CAMS nurses who've needed to take some time off because of personal things. One lost her own baby in a miscarriage. Another had a teenager who was going through a crisis. So it's really important to recognize and have adequate management structures to try and mediate that, because that's not always understood by general sort of hospital management in terms of the load. And likewise with our community workers, I can't really overemphasize the need for supervision in any model. So at district hospitals, which is the backbone of our service together with the clinics, our model is really built very much on an outreach program. Both psychology and psychiatry are involved in outreach. There's a training of medical officers in mental health, in the mental health diploma, in which there's a child and adolescent component. We also have been involved with the help of our 3 district coordinators for those 3 districts in district training, getting all the people together, who are part of the mental health team at district level, then providing training at the district office. We've tried to provide specific support, equipping and training for our CAMS nurses. We have WhatsApp groups for referrals and for general chat and support. We've also been given some donation of toys, and it's received with so much joy. Yeah, it's very nice when that's the case. The collaboration with our district mental health coordinators has been very key, and engaging with district hospital management. And we've tried to offer telephonic and WhatsApp support on an ongoing basis. So at tertiary hospital level, I think as Renee referred to, the intersectoral collaboration in terms of CAMS is really important. Interdisciplinary collaboration. We've been involved with some mental health training with the pediatric team, upskilling the psychiatry staff themselves in terms of CAMS. We have a weekly child and adolescent psychiatry clinic and a child mental health clinic at Kwinandi. We also have a Thuthuzela Center based at Ngwelezan, providing psychology and social work service for sexual abuse survivors. We also provide forensic services for child and adolescent victims and perpetrators. We have an ASD support group that's just started at Kwinandi. And then I think what's been really wonderful is the kind of integrated mental health care that's happened with development of CP services. I know you're going to be hearing about that a little bit later on. Other long-term medical health conditions, getting involved where kids have been involved in trauma. There's a new initiative in terms of palliative care. We're quite involved with the neurology clinic at Kwinandi, infant mental health and maternal mental health. And so I thought I'd just I hope this is going to play.
Jill?
Yeah.
We're very close to being out of time,
Okay,
but
All
I
right.
think if we can.
let me go. Okay. All right. Okay. I suppose the important thing maybe just to go is just building within this system a referral network. Our needs is our near absence of adolescent services that's been talked about, educational psychology services. Our challenges are our distances, the burden of care and the cost of empathy, the enormity of the task, a lack of space, a lack of recognition, and the work of integration. Our approach has been step by step. We focused on growth. We're trying to focus on what we have, not what we don't have. We try to build where we find traction. We try to build in support and supervision at every level, and recognize that the need will always outweigh the available resources, so to be realistic. So just to acknowledge that this is the work of a team. And so those are some of the people who've been involved. And yeah, thanks very much.
Thank you very much. As you can hear, there's a lot to talk about, and I think this is one of the first times we've really dived in deep to mental health. Yeah, and it's very exciting to have the cross-fertilization. So the final speaker is Jenny Nash, who I'm sure is familiar to most people in the room. She's a family physician working in a district clinical specialist team in the Eastern Cape in the Amatolo district.
Afternoon, everyone. This is definitely the last speaker, so you can start dreaming about your coffee. So I'm representing a team, as I've mentioned here, from Department of Education, Social Development, and Justice. This is a very new, that's why I'm calling it tweenie steps. We kind of feel like we're kind of 6-10-year-olds. And when you've heard the amazing work that's happening in other provinces, I really want to emphasize in the Eastern Cape, this is our province. We have many challenges. If we drive from the sort of Kokstad side of the Eastern Cape down towards the Western Cape side, if you drive according to the speed limit, avoiding potholes, goats, horses and cows, it probably takes you about 10 hours on the N2. So we have a big challenge that you can see there in terms of population. Most of our population is towards the east of our province, and then around the metros. And unfortunately, most of our tertiary services are centered in Nelson Mandela Bay Metro, which is the Gqeberha area, and East London and around Mthatha. So we already have this discrepancy of services in terms of where things are. And so some background, in 2017, there were a number of damning reports that were made around the lack of mental health services in the Eastern Cape. In 2019, the Mental Health Directorate was placed under administration, and Prof. Mkhize was sent to try and help sort things out. COVID came along, and unfortunately, he passed away during the COVID pandemic, and we can really say that not much has happened since. And so over the last couple of years, we've seen a dwindling of public sector psychiatrists. And when I was trying to add up with my hand, I think in 1 year we dropped down to 9 for a population of about 6.6 million. And so at the beginning of this year, a group of fairly frustrated clinicians came together, and we decided to try and resurrect some services. Slowly, a group of people emerged, and this included representatives from psychiatry, but also from the infrastructure team, from a neurologist, some provincial managers, and this task team started to meet every week and started to get some ideas together. We started camping out at some provincial offices, and on the 1st of August, a provincial directorate for mental health services was appointed. And thereafter, we've had our mental health review board members appointed and trained. And then in August 2022, a meeting was held to establish a team that would work together, specifically looking at adolescent and child health. So this CAMS is a new language. Okay, in the Eastern Cape, we or just do a bit of everything. And this team came together with some initial fairly reluctant members from Department of Social Development, Justice and Education. And what this has meant is that we've had the chance to start looking at children who really have severe difficulties and are living in very, very sometimes dangerous situations. LK was a young lady who actually went and camped out at the magistrate's office for a couple of hours. She was discharged to her father and stepmother from a regional hospital after she'd been there for 15 months because they basically didn't know what to do with her. Her diagnosis included bipolar, ADHD, conduct disorder, intellectual disability, query with underlying fetal alcohol syndrome, spectrum disorder, and hypersexuality. And 2 days after she was discharged, she was taken to the nearest district hospital because she had assaulted her father. And her father had said that basically the stepmother had said, you can choose between me or the child. While in the district hospital, she caused absolute havoc, and self-harming herself, some of the patients, putting some of the doctors and healthcare workers at risk. And this was one of the patients that came to this group actually during COVID, but subsequently we have tried to meet together. RM is a 17-year-old young lady who was placed in foster care following the death of her biological parents in 2017. And the placement was going quite smoothly until December 2019, when she started demonstrating some serious behavioral challenges. And so she was moved into a child and youth care center in a distant metro. There she absconded twice. She was found in a nearby brothel. She was often found drunk. And so she was immediately sent back to her rural town. So medication was commenced, but the appointed caregiver really struggled to administer the medication. And she subsequently has absconded a number of times. In fact, even when I was starting to prepare this presentation, I wasn't actually sure where she was. She's had multiple sexual partners. She abuses substances. She steals money. She lies, and she frequently runs away. And so what we found in looking at some of these children and adolescents, there's incredible unstable family environments. There's erratic adherence to medication, usually because of the social situations. Usually the children and adolescents have dropped out of school. There are outstanding court orders. No one really knows where they should be, and there's a backlog. And we really struggle with mental health beds for adolescents. We've also found a reluctance of healthcare workers to manage these complex adolescent clients at district level, and everyone seems to just want them to go somewhere. We've actually approached some of our colleagues in other provinces for assistance. It's been a dire situation. And we've also found that there's lack of mental health support. We work in a district where we have about 890,000 people. We don't have a single psychologist in that area, which is hopefully changing. And so some of the activities of this multidisciplinary team, we're invited to participate in one of these Western Cape mental health strategic huddles that Jürgen Pille mentioned earlier today, which is very enlightening. And then we've had the opportunity to visit a number of facilities around the province, really looking at what facilities are there for 18-year-olds, what facilities are there for less than 18-year-olds. It's been very sobering to see what facilities there are. We also had the chance to meet with one of our clients as a multidisciplinary team, and that was really important. And we've tried to provide telephonic support to hospitals, district hospitals, where some of these adolescents are admitted. And so what we found in working as a team, it's building relationships with different departments. You've had to trying to work out what common times are, what acceptable forms of communication, trying to find out the hierarchy of who do you address as who, and what we actually have found is that a really good way is just to, what we found is traveling together to different different facilities has allowed us to get to know each other. And so we found that there are deficiencies in all our sister departments as well. And we need to start duplicating some of these teams. So going forward, we want to continue to learn from other provinces what you colleagues are doing, and to continue to build relationships within this partnership to strengthen referral patterns and pathways within these different sectors. We've got a couple of developments happening in the next few weeks where we're hoping some more healthcare workers will be appointed and an adolescent unit will be opened in Makanda. Thank you.
Thank you very much, Jenny. I'm mindful that we are at 5 o'clock. I want you to ask the room if we could have 5 minutes for questions. Just because I think for me, there are 101 questions about how on earth are we going to turn the system around? Mandy.
I just had 2 questions from my experience of watching Jill build the service at Queen Nandi, which has been an amazing thing to watch. And one of them was about, are there norms and standards for the time that it should take to consult in these patients? Because I think that is something that the medical fraternity don't understand. So when you're going to a management meeting and saying why you need so many more personnel, they say, but they're only seeing this many patients per day. There really is a lack of understanding that you need to sit with a child like this for well over an hour sometimes, where a doctor might in that time see 6, 7, 8 patients if they're simple things in the POPD. So I was just wondering, when we're going to our facility managers to motivate for staff and advocate, are there norms and standards to sort of how many people we should have for a population size? Because that's often a good place to start. And the second thing is, for the ordering of our psychological tests, I remember we went through that, Jill, where it was quite difficult where to put that on your business plan. And we sneaked those tests in under the pediatric business plan just to try order them, and then found how difficult it was to lock those really expensive tests up in a safe place. So those sort of things, they need to become more easily available. I think in the state sector, we want to get those tests and we want to get some sort of norms and standards so that we can go and motivate, because they exist for nursing and they exist for medical, and that makes it a little more easy. I don't know who I'm asking, sorry. Just
yeah. Manny, I don't actually know if there are norms and standards. I'm not aware of any. There might be some somewhere. Yeah.
Mandy, on that side. There.
I'm not aware of any norms and standards related to the time that is that should be allocated for different conditions or seeing children, but there were norms and standards that were developed for staffing given the population for each province in 2004. So what they did was they developed norms and standards for human resourcing, and they recommended the bare minimum. So they did it across a range, what would be ideal and what would be the minimum, but it was never implemented. So it was a report that was commissioned by the Department of Health themselves, but it was never implemented.
Thank you very much. Excellent presentations by all. I just want to know about monitoring. I mean, we have to motivate for this, right? No one disagrees with that. And to motivate, you require data and evidence to say these things are great. So my question is, and it's not just the neurologist or the psychologist, or everyone needs to motivate. As child health professionals, we all need to motivate. So we need to have some sort of yardstick of how we can convince the powers that be to actually invest in this. So is there some guidance that we can have from the committee to say, this is what we need to do as a team, rather than just leave it among y'all? Thanks.
Thank you. Thank you. I think this question I'm going to ask is also kind of related to those norms and standards. Jill, what you've presented is so interesting, and I think shocking at the same time to see the wide variation, amongst the provinces in terms of the recognition of staff and their expertise, such that it impacts very negatively on the staff ratios and retaining the staff. Currently, in our province, we are losing, mental health nurses for camps at primary level and at tertiary. It's really shocking. And looking back at the research, which also one of the themes that came up was lack of acknowledgement, especially for mental health nurses, you know, of their skills, which make them move, you know, to other areas. And the child and adolescent mental health area is the one that loses, you know, the most. To see what's happening in KZN, that when they join the training, there's recognition, there's even incentives. I mean, the stuff that you've outlined there, it's really, you know, so amazing. And it's very much opposite to what we are experiencing. So my question is, I wonder, why is this wide variation, you know, of the recognition and acknowledgement of mental health within the provinces, such that one province has got a mental health manager and the other one doesn't see it, you know, important to you know, to have? How can we standardize this across our country so that we don't have this province going? It's like each one is doing their own thing. We're working in silos, you know, as Renee also indicated earlier on. This sub-district, they choose whether they're going to have a mental health coordinator or not. Why is that allowed? Why can't we standardize and have the same norm so that all we have equity, you know, in our staffing and retaining our personnel for child and adolescent services?
Yeah, I think that as you say, the thing that has stuck out for me is the need to support and recognize the value, but also the cost of what people do. And that in recognizing that, they feel supported. It's absolutely key. It's absolutely key.
I just want to answer the question up there about how do you make the case? So we've got a fairly old study that estimated prevalence for mental disorders for children and adolescents is about 17%. There haven't been any recent ones. But what they were doing through COVID was that they started to look at other data sets. And at a strategic huddle that I attended, there was a presentation where there was an acknowledgement that the burden of disease for mental health has increased. Now, how did they do that? They actually have been tracking ICD-10 codes. So you can see admissions to an emergency unit, entry into a primary health care. The data isn't as good at primary health care as it might be at district and other centers, but we have seen a rise. And then there have been other ways of making the case. We've had some very unfortunate incidents, and that's an infrastructure issue, but also the numbers of patients entering emergency care centers is absolutely overwhelming. So you can have a unit with a bed capacity of 30 with 80 patients arriving on a particular day. And so they've been very good at tracking. There is a system that's been rolled out called Hectus. I forget every time what Hectus means, but it's a way of plotting the journey of a patient through data monitoring, and you'd be able to see what percentage or component of patients are mental health users.
Just a quick response as well, is that a lot of the onus is on provincial level, at the provincial level. I know Leslie Bamford's just left, but national can give recommendations to provinces, but it's up to provinces then to decide how to implement strategies. And I think we as clinicians need to be far more proactive now in saying what are some of the recommendations coming through. And if our provinces are not implementing that, what is our responsibility? Do we sit back and say we don't have a mental health service, we don't have a whatever service, or how do we involve civil society? How do we involve other sectors to put pressure on our provinces to demand equal services? And so I think this is, the game is going to change. But I think it means clinicians need to be more involved on knowing what we should be implementing so that we can implement. And the example was given recently of the HIV program and how the HIV program really changed because of active citizenry and clinicians getting involved and really saying, have we sat back now and decided that actually we've got our HIV program and so everything is fine? Where else can civil society be getting involved? Mental health is a huge issue. It's the orphan child, and we need to be, it involves everyone. And this is, I think, the platform where we should be saying to civil society, we should be saying to our schools, to every other sector, this is where we should be getting involved, whether it's with adolescents, which is in this context, but for adults, you know, etc. So I think there's perhaps a move now to try and put pressure on provinces to be doing what should be done.
Thank you. I'm aware we're sort of now over time, but I want to thank you all for the opportunity to engage in the really sharp and pointed questions and the call for greater equity and activism around this issue. I do want to point you to the latest issue of the South African Child Gauge, which includes a series of recommendations for how the mental health system within health can be strengthened, but also what's required from other sectors and also from families. And there's a short policy brief which will pull out the headlines for you. And then just to alert everyone that there is a petition calling on the Minister of Health and Minister of Treasury to increase investment in CAMS. And really, we do need the money to make this work. So I'll share the link to the petition tomorrow morning, and I would just encourage you to sign it and then to share it with anyone you know who cares about child and adolescent mental health. And what struck me with work on this issue of the gauge is it's not just people working in health who are concerned. It's mothers and fathers and family members who are worried about the young people in their lives. So we need to be mobilizing that support across society. Thank you very, very much.
Thank you, everyone. Thank you.